So today we are going to discuss the renal failure and hyperkalemia station from critical care. So 78-year-old lady with a dementia and renal impairment, history of recurrent UTI, baseline creatinine 250, and now developed UTI, nausea and vomiting. So lab shows APG metabolic acidosis with a high anion gap, electrolyte hyponatremia and hyperkalemia. So this is a very common picture whenever there is a renal impairment. So you will get hyperkalemia and hyponatremia and maybe metabolic acidosis, but it also depends on the cause as well. So what is your interpretation with the lab results? So low sodium, high potassium and creatinine suggest AKI, acute kidney injury due to obstructive uropathy, because he has a history of recurrent UTI and renal impairment already in dementia. Uh, so so this may be due to obstructive uropathy and perirenal due to decreased oral fluid intake due to dementia. So this can be the cause of AKI, and she has also previous history of renal impairment, so there can be acute on chronic kidney injury. The patient had urinary catheter inserted, drained 1500 ml, then 4 liter per day. Why? This is the diuretic phase of AKI, which occurs after correction of the cause. So whenever there is a AKI, so there are like three phases for the reversal. So one of the cause is a diuretic phase. One of the phases diuretic phase. So maybe this 4 liter per day because of this. Okay, so pathophysiology of polyuric phase. So due to recovery of the glomeruli first with no improvement in distal tubules, which will lead to increase in GFR, increased urine output with dehydration and inability of the kidney to concentrate urine. Okay, so you will be wondered that why there is a diuretic phase. So diuretic phase is because when we have AKI, suppose, and it is recovered back. So when it is recovered, first function is restored back to the glomerulus, Bowman capsule, and this glomerulus. We have this glomeruli. Okay, so we have also the tubules here. So the glomeruli function is restored, but there is no function in the tubules, the renal tubules. So what happens that they are unable to concentrate the urine. For example, the absorption and absorption of the fluids and various electrolytes. So that's why maybe we have a diuretic phase. Okay, so this is why that the kidney is unable to concentrate the urine. So we have this diuretic phase. So why are uremic patients anemic? Why are uremic patients anemic? So uremic patient may develop a normocytic normochromic anemia for a number of reasons. So there can be deficiency of erythropoietin, most important cause, because kidney is the organ which secretes erythropoietin. So if there is if there is chronic kidney failure, CKD, there will be no erythropoietin. Presence of circulating bone marrow toxins, bone marrow. So we have this, kidney is the purifier of the body. So if there is kidney problem, there will be toxins in the body. This can suppress the bone marrow cells, hematopoietic cells. Bone marrow fibrosis due to during osteitis fibrosa cystica. Okay, so this is another problem. The kidney, when it is in CKD, chronic kidney failure, so we have loss of calcium. We have loss of calcium. So when there is loss of calcium, so body has increased amounts of parathyroid hormone, which we call is hyperparathyroidism, secondary hyperparathyroidism. So this will lead to demineralization of the bone. So we have osteitis, fibrosa cystica, we have cysts in the bone and demineralized bone and weak bone. So there will be fibrosed marrow as well. Increased red cell fragility caused by uremic toxin. Since the red blood cells are very sensitive, so uremic toxins can make them fragile, so they are very easy to rupture. So these are the different various causes which can cause anemia in CKD or uremic patients. Okay, so what is osteogenesis fibrosing, how it is related to renal failure? So osteogenesis fibrosing is a skeletal disorder caused by overproduction of parathyroid hormone from overreactive parathyroid glands. CKD leads to secondary hyperparathyroidism, increased osteoclastic activity, calcium turnover, rapid bone loss, vascular proliferation, and fibrous tissue, replacement of normal marrow content, anemia. So this is the sketch. Okay, what are the functions of potassium? Potassium is essential for maintaining proper fluid balance, nerve impulse, and most important, we have the cardiac functions, muscle function, cardiac function. So there will always be a problem with the cardiac conductivity and electrical activity. So how hemostasis of potassium is maintained? There are a number of influential factors on serum potassium. Gastrointestinal diet can also, like the Tetra Pak juices and bananas, they have a lot of potassium. So in CKD patients you have to be very careful. Endocrine, aldosterone, this mineralocorticoid produced by the zona glomerulosa of the adrenal gland simulates sodium reabsorption in the distal convoluted tubules and cortical collecting ducts through an active exchange with the potassium. So it promotes its excretion. Insulin stimulates potassium uptake into the cell, reducing serum level. Renal acid-base balance, potassium and hydrogens are exchanged in the cell membrane, producing reciprocal changes in concentration. Acidosis leads to hyperkalemia. Similarly, alkalosis can lead to hypokalemia. Tubular fluid flow rate, tubular flow rate. So tubular fluid flow rate, increased flow promotes potassium secretion. One method by which diuretic can cause hypokalemia. Okay, so let me summarize these causes of the potassium hemostasis. So gastrointestinal, getting more potassium in food will lead to hyperkalemia up to some level, but body can maintain it. Okay, so aldosterone intake sodium and secrete potassium. So aldosterone will cause hypokalemia if it is like in large amount, excessive secretion. Insulin do reuptake into the cells. So this is cell suppose. So insulin always push potassium into the cell because it's in mechanism of the insulin work. Renal acid-base balance. So what happens that we have in the renal tubules we have this pump which can reabsorb sodium, and can secrete potassium either or H plus. Okay, so it can push. So in situation where there is acid-base balance, disturbance, acid-base disturbance, so the body shift from potassium to hydrogen. So in response to sodium, it will push out potassium. So potassium and H plus ion are exchanged in the cell membrane, produce a reciprocal change in the concentration. So what will happen that if there is if we have acidosis, body will build up potassium because body will be busy in throwing out hydrogen. So behind we will have large amount of potassium. Okay, so instead of secreting potassium, body will be busy in secreting or get rid of hydrogen, and so there will be buildup of potassium. So hyperkalemia is associated with acidosis. Okay, and hypokalemia vice versa with the alkalosis. Tubular fluid. Okay, so these are the tubules of the renal So if there is a high flow rate of the fluid through the tubules, there will be loss of potassium and other these electrolytes as well. This is one of the mechanism by which diuretics work. They increase the fluid flow rate, so in the process there is loss of electrolytes. What is the action of potassium on the cardiac muscle mechanism? So excess potassium causes heart to be dilated, flexed, and decrease the heart rate and can block the conduction of cardiac impulse. They can ask you these conceptual questions, believe me, and they have asked already some of the candidates as well. So you have to be very sharp for this potassium exchange mechanism and this one. So what will happen that the we have the action potential. So we have normal, let's suppose we have normal this threshold. So if there is excess potassium outside, so cardiac membrane, this will the let's suppose normally the threshold is here, so the threshold for in case will decrease in case of high sorry, the threshold will increase because we know that potassium inside is high. So if potassium inside is high and outside is high, so there will be a lot of work to carry out the action potential. So the you can say the threshold gets high for the contractility or for the stimulation of the cardiac impulse or cardiac contraction. So what happens that excess potassium causes the heart to be dilated, flexed, and decreases the heart rate, and again block the conduction of cardiac impulse. High potassium depolarizes the resting membrane potential, causing it to be less negative, which will decrease the intensity of action potential, making the concentration making the contraction weaker. So normally we have potassium, and inside we have the okay. I will make a separate video for this specific action potential thing.